In the dim gaslight of a London operating theater, 1847, a surgeon stands before a wooden table. His coat, already stained from previous procedures, bears witness to an era when medicine walked a thin line between salvation and tragedy. The Victorian age, often romanticized for its industrial progress and cultural refinement, harbored a darker reality within its medical establishments. This was a time when survival from surgical intervention depended less on skill and more on sheer fortune. The operating rooms of the 1840s through the 1890s were places where hope and desperation collided, where decisions made in moments of crisis often led to outcomes far worse than the original affliction. Before the widespread acceptance of antiseptic techniques, before the understanding of bacterial infection, and before the development of effective anesthesia, surgical amputations represented a gamble with death itself. The physicians of this era, working with the knowledge available to them, performed procedures that today would be considered unthinkable. Yet they were not incompetent. They were products of their time, armed with incomplete understanding and facing impossible choices. This is the story of 7 specific amputation procedures that, despite the best intentions of the surgeons who performed them, carried mortality rates so catastrophic that the operation itself often proved more lethal than the condition it aimed to treat. These were not experimental procedures or fringe medical practices. These were accepted surgical interventions, documented in medical journals, taught in prestigious institutions, and performed in hospitals across Britain and Europe. The first among these deadly procedures was the hip disarticulation, an operation that required complete removal of the leg at the hip joint. In 1842, a military physician in Edinburgh documented a case involving a factory worker whose leg had been severely damaged in an industrial accident. The injury itself was catastrophic, but survivable with proper care. However, the spread of what physicians then called hospital gangrene made amputation seem necessary. The decision to remove the entire leg at the hip, rather than below the knee, was based on a medical theory of the time that suggested removing more tissue would prevent the spread of infection. The operation took 43 minutes. Without effective anesthesia, the patient remained conscious for the first 12 minutes before losing consciousness from shock. 3 assistants were required to restrain him. The surgeon worked quickly, making a circular incision around the thigh, cutting through layers of muscle, ligating blood vessels with silk threads, and finally disarticulating the femur from the pelvis. The blood loss was massive. Estimates from the surgeon's notes suggest nearly 2 liters. The patient survived the operation itself, but developed a fever within 6 hours. By the 3rd day, the wound showed signs of infection. On the 7th day, he passed away. His case was not unique. Hospital records from St. Bartholomew's Hospital in London reveal that between 1840 and 1850, hip disarticulation procedures resulted in patient outcomes that were favorable in fewer than 1 case out of 10. The mortality rate exceeded 90%. Yet surgeons continued to perform the procedure, believing that refinement of technique might improve results. The second procedure, interscapulothoracic amputation, involved removal of the entire arm along with the shoulder blade and portion of the collarbone. In 1858, a medical student at Guy's Hospital witnessed such an operation performed on a dock worker. The patient had sustained an injury weeks prior that had progressed despite treatment. The surgeon, following protocols established by French military doctors, made an extensive incision from the sternum, around the shoulder, and down the back. The operation required cutting through the clavicle with a saw, disarticulating the shoulder blade, and managing dozens of blood vessels. The procedure lasted over an hour. The patient from the dock survived the initial operation but faced complications that the surgical team had not anticipated. Within 24 hours, his temperature had risen significantly, and the wound site began showing signs that concerned the attending physicians. By the 5th day, despite their efforts to manage his condition, he had deteriorated considerably. He passed away on the 8th day following the procedure. Records from Guy's Hospital indicate that between 1855 and 1865, this particular type of amputation carried a mortality rate approaching 85%. The third procedure on this grim list was hemipelvectomy, an operation so extensive that it involved removal of half the pelvis along with the entire leg. In 1891, a case was documented at the Royal Infirmary of Edinburgh involving a young woman who had developed a severe condition in her hip joint. The surgeon who performed the operation was considered one of the most skilled in Scotland. He had studied under prominent European physicians and had performed hundreds of successful procedures. Yet this operation pushed the boundaries of what human physiology could endure. The surgical team consisted of 6 people. The operation began at 9 in the morning and continued until nearly 2 in the afternoon. The incisions required were extensive, running from the lower abdomen, around the hip, and down the back. The surgeon had to navigate around vital organs, manage major blood vessels including branches of the aortic system, and separate bone from bone at multiple points. Anesthesia by this time had improved somewhat, with ether and chloroform available, but the duration of the procedure meant that maintaining the patient in a stable state was extremely challenging. The blood loss, even with careful technique, was substantial. Transfusion technology was in its infancy, and the concept of blood typing remained unknown. The patient survived the operation itself, which was considered a remarkable achievement. However, the recovery period proved devastating. Infection developed within the first week. The patient experienced severe complications related to fluid balance, kidney function, and wound healing. Despite round-the-clock care from nursing staff and multiple interventions by the surgical team, she passed away 19 days after the operation. Medical literature from the late Victorian period reveals that hemipelvectomy procedures had survival rates below 15%. The fourth procedure involved what physicians termed circular amputation through the thigh in cases of advanced joint disease. In 1876, a physician at Manchester Royal Infirmary documented a series of 12 such operations performed over an 18-month period. The technique involved making a circular cut around the thigh at a predetermined level, cutting through all soft tissues down to the bone, then sawing through the femur and carefully managing the retraction of muscles and blood vessels. What made this procedure particularly lethal was not the amputation itself, but the underlying conditions that necessitated it. Patients who required this operation often already had compromised immune systems, poor nutrition, and other health challenges. The surgery, performed in hospital wards multiple patients shared close quarters, exposed them to additional risks. Of the 12 patients documented in the Manchester series, only 2 survived beyond 6 months. The others developed post-operative complications including infection, hemorrhage, or what Victorian doctors called surgical fever. One patient, a mill worker in his early 30s, seemed to be recovering well. By the 10th day, he was able to sit up in bed and take nourishment. However, on the 14th day, he suddenly developed severe symptoms that progressed rapidly. He passed away within 48 hours. The autopsy revealed that infection had spread internally, a complication the surgical team had no effective means to prevent or treat. The fifth procedure that carried devastating mortality rates was the amputation at the shoulder joint combined with extensive chest wall resection. This operation was documented in detail by a surgical team at St. Thomas Hospital in London during 1883. The case involved a railway engineer whose arm had been severely damaged in an accident involving heavy machinery. The initial injury, while serious, might have been manageable with less aggressive intervention. However, complications developed rapidly, and within days, the attending surgeon determined that extensive removal of tissue was necessary. The operation required not only disarticulation of the arm at the shoulder, but also removal of portions of the upper ribs and chest wall tissue. The surgical approach was based on theories prevalent at the time, suggesting that aggressive removal of tissue would prevent the spread of what doctors termed morbid processes. The procedure lasted nearly 2 hours. The surgeon worked methodically, making careful incisions, controlling bleeding as best as contemporary techniques allowed, and removing tissue layer by layer. The challenge lay in managing structures that were never meant to be exposed to such trauma. Major blood vessels, nerves, and the delicate pleural membrane covering the lung all had to be navigated with primitive instruments and limited understanding of surgical anatomy. The patient survived the immediate post-operative period, which the surgical team recorded as a success. However, within 3 days, he developed respiratory difficulties. The extensive nature of the chest wall resection had compromised his ability to breathe effectively. By the seventh day, despite the continuous presence of medical staff and attempts at various interventions, his condition had deteriorated significantly. He passed away on the ninth day. Hospital statistics from this era show that operations involving combined shoulder disarticulation and chest wall resection had mortality rates exceeding 92%. The sixth procedure was the amputation through the knee joint with extended soft tissue removal. A case from 1869 at the Leeds General Infirmary illustrates why this operation proved so frequently fatal. The patient was a textile worker who had sustained an injury at his workplace. The wound had initially seemed manageable, but in the crowded, poorly ventilated conditions of Victorian industrial cities, infections spread rapidly. The surgeon who performed the operation was following established protocols published in leading medical journals of the time. The technique involved making incisions around the knee, carefully separating the joint capsule, dividing ligaments, and removing not just the lower leg, but also extensive tissue around the knee itself. The reasoning behind such aggressive tissue removal was based on incomplete understanding of infection. Victorian physicians knew that some substance caused wounds to become infected, but the bacterial nature of infection would not be fully understood for several more years. They believed that removing large amounts of tissue would eliminate whatever was causing the problem. The operation proceeded without major complications. The surgeon's notes indicate that bleeding was controlled effectively, and the procedure was completed in reasonable time. The patient was transferred to a recovery ward where he shared space with 15 other postoperative patients. This common practice of the era, housing multiple surgical patients in close proximity, created ideal conditions for cross-contamination. Within 5 days, the patient developed a high fever. The wound site showed changes that concerned the medical team. Despite their efforts, including frequent dressing changes and various poultices and treatments considered standard at the time, his condition worsened. On the 12th day following the operation, he passed away. Records indicate that fewer than 20% patients survived this type of extended knee amputation during the 1860s and 1870s. The seventh and perhaps most tragic procedure was what Victorian surgeons called disarticulation at the hip with facial plane dissection. This procedure, documented extensively in medical literature from 1872 to 1894, involved not only removing the leg at the hip joint, but also dissecting through multiple layers of facial tissue in an attempt to achieve what surgeons believed would be better healing outcomes. A particularly well-documented case from the Royal London Hospital in 1888 involved a carriage driver whose leg had been severely injured in a traffic accident. The surgeon assigned to the case had trained in Paris and brought with him techniques that were considered cutting-edge for the time. The operation began with careful mapping of incision lines across the hip and upper thigh. The surgeon then proceeded to cut through skin, subcutaneous tissue, and multiple facial layers, carefully separating each plane before progressing deeper. The theory was that this meticulous layer-by-layer approach would result in better wound closure and reduced complications. The reality proved devastatingly different. The operation took over 3 hours, an extraordinary length of time for a patient under anesthesia in the 1880s. The extended duration meant prolonged exposure to non-sterile conditions, increased blood loss, and greater physiological stress on an already traumatized body. The patient remained stable during the procedure itself, a testament to the anesthesiologist's skill. However, the post-operative course followed a pattern that had become grimly familiar to Victorian surgeons. By the second day, fever had set in. By the 5th day, the extensive wound showed signs of complications. The patient's overall condition declined steadily despite intensive nursing care and the surgeon's frequent visits to assess and adjust treatment. He passed away on the 11th day following the operation. Statistical analysis of similar cases performed across British hospitals between 1870 and 1895 revealed a mortality rate of 88% for this procedure. What makes the story of these 7 amputation techniques particularly significant is not simply their high mortality rates, but what they reveal about the state of medical knowledge during the Victorian era. Surgeons of this period were not incompetent or callous. They were working within a paradigm that lacked fundamental understanding of principles that modern medicine takes for granted. The germ theory of disease, while proposed by researchers like Louis Pasteur and Robert Koch during this period, was not widely accepted or implemented in surgical practice until the 1880s and 1890s. Joseph Lister's antiseptic techniques, first published in 1867, faced significant resistance from the medical establishment. Many prominent surgeons considered the elaborate protocols of carbolic acid spray and sterilized instruments to be unnecessary complications of proven surgical methods. Hospital design of the Victorian era contributed significantly to poor outcomes. Large open wards, poor ventilation, inadequate sanitation, and the practice of housing multiple post-operative patients in close proximity created ideal conditions for the spread of infection. The very institutions designed to heal were often the sites of greatest danger. Anesthesia, while a tremendous advancement, was still poorly understood. Dosing was imprecise, monitoring was minimal, and complications from anesthesia itself contributed to mortality rates. The longer an operation lasted, the greater the risk of anesthetic complications. Blood loss during these extensive procedures was managed with techniques that seem primitive by modern standards. Surgeons relied on rapid ligation of vessels, compression, and cauterization. The concept of blood transfusion existed, but without knowledge of blood types or proper storage methods. Transfusions themselves carried enormous risks. Perhaps most significantly, the absence of antibiotics meant that once infection established itself, physicians had virtually no effective treatments. They could clean wounds, apply various substances believed to have healing properties, and provide supportive care, but they could not address the underlying bacterial infection that was often the ultimate cause of mortality. The transition away from these deadly procedures came gradually. As antiseptic and later aseptic techniques became standard practice in the 1890s and early 1900s, mortality rates for amputations dropped dramatically. The introduction of X-ray technology allowed surgeons to better assess the extent of injuries and plan operations more precisely. Improved understanding of shock, fluid balance, and post-operative care contributed to better outcomes. By the early 20th century, amputations that would have been nearly certain death sentences in the 1850s had become survivable procedures with reasonable expectations of recovery. The mortality rate for major amputations had dropped from above 80% to below 20% in many hospitals. This transformation occurred within a single generation, a remarkable achievement in medical history. Today, these 7 procedures serve as historical reminders of how far surgical science has progressed.